Hello, everyone. Welcome to the Culinary Medicine Interest Group podcast. With us here, we have Dr. Mullally, an endocrinologist at Westchester Medical Center. I'm going to let her introduce herself and kind of explain her practice a little bit.
Hi, John. Thanks so much for having me today. A pleasure to be here. So a little bit about me. I've always been interested in nutrition. I took several nutrition classes in undergrad at Cornell and went on to medical school, and vividly remember sitting in the diabetes prevention program lecture and being amazed that you could prevent diabetes with lifestyle changes alone. In fact, the lifestyle changes were superior to medication at preventing diabetes, and found myself interested in preventive cardiology. Went on to my residency at Cornell, and during my second year there was able to do an endocrinology and an obesity medicine rotation, and worked with Lou Aroney, who's one of the pioneers in the field of obesity medicine, and found it, really satisfying seeing patients with him. He was very successful in helping them to lose weight, and they were, feeling very healthy, happy. They were able to reverse their diabetes, their high blood pressure, their high cholesterol, and come off medicines for these conditions. And just found that this approach made a lot more sense rather than targeting these individual comorbidities with more and more medications to control them. So found this very satisfying and decided to go into endocrinology and obesity medicine. So did my fellowship at Columbia and worked with Judy Corner there, doing research looking at hormonal mechanisms for the success with bariatric surgery and genetic determinants of response to one of the anti-obesity medications, and ended up becoming board certified in obesity medicine as well, and then worked at the Weight Control Center at Columbia for a few years and joined Westchester Medical Center about a year ago. And here I do general endocrinology and am establishing a metabolic and weight control center as well. So I get to continue to see patients for obesity and help them lose weight.
Amazing. Thank you for sharing. It's a nice, long story to get to where you are now, but very interesting. And you've already touched a lot on what we wanted to start asking about, which is obesity as a serious multifactorial chronic disease. And you started to touch on some of those different factors, but I was wondering if you could elaborate a little bit more on what some of those factors are, as well as how obesity is more recently being framed as the disease that it is rather than the cosmetic issue that it has been looked at in as the past.
Yeah, so I think we're faced with an epidemic of obesity now, and historically, it was just felt that people should eat less, they should move more, and we would fix this problem. And clearly, it's not that simple. And obesity is a disease, just like hypertension is a disease of blood pressure regulation. Obesity is a disease of weight regulation. It's not just a lack of willpower. It's complex. It involves genetics, epigenetic, environmental, neuronal, hormonal, behavioral factors. And weight loss is very difficult for patients. So even in, well-designed controlled studies where people lose over 10% of their weight, only about 10 to 20% of people will maintain a weight loss at a year after the study. And there's well-recognized factors that contribute to this. We have metabolic adaptation, where resting metabolic rate slows much more than predicted after a weight loss. And then we see this long-term persistence of hormonal changes where we have higher levels of hunger hormones and lower levels of satiety-promoting hormones, which all contribute to the patients being hungrier and, being likely to regain the weight. So it's difficult for patients. And then I think the second part of your question was the comorbidities related to weight loss. So what I see in my practice as an endocrinologist, type 2 diabetes is probably the most frequent comorbidity I see. And this is related to the inflammatory properties of adipose tissues, then cardiovascular disease, increased risks of many types of cancer. And then other patients have issues related to just the excess mass of the adipose tissue, like osteoarthritis of the knees or obesity hypoventilation obesity hypoventilation syndrome. So obesity really affects all the organs and systems of the body and really see it all. And weight loss improves all of these comorbidities.
Yeah, thank you so much for sharing all of that, and ways that you can help, like you said, through weight loss, address some of these comorbidities that otherwise in the past we might have done with a lot more excessive treatment regimens. And now we're learning more about how nutrition and how diet and how all these lifestyle factors can really play a role in some of this prevention and management and long-term sustainability as well, which I think is really exciting to see that shift in medicine and to see that emerging more. I wanted to touch upon, one of the concepts that you were speaking on before was this idea of how things have changed from the past to the present, and one of the tools that we see used a lot when it comes to weight and obesity medicine as well is the concept of, BMI and measuring BMI. And it's often very much criticized just because of its failure to include certain things like muscle mass, bone density, body composition, and take into account some of these other factors that we see, like racial, sexual differences as well. So I guess we would love to hear your thoughts on this tool or what you currently use in practice to track your patients' progress.
Yeah, so I think we use BMI because it's easy to measure and it's readily available. We are measuring patients' height and weight, so we have it available. But I think it absolutely has all of the limitations you've described, and we need better tools to really measure a patient's metabolic risk from their weight. So one other tool that's readily accessible in the office is measuring waist circumference. We know that a person's distribution of body fat makes a big difference in their health risk. And if you have more central adiposity, this is riskier than somebody who's more like a pear shape and maybe has more adiposity in the legs or the buttock region. So I do routinely measure waist circumference, and I factor the waist circumference into determining the metabolic risk for the patient. And what is becoming more readily available is body composition analysis. So you can get a bioimpedance scale for the office. There are even home units available, but you can use bioimpedance to measure body composition. It's not quite as good as our gold standard of DEXA or MRI for measuring body composition, but I think it is a helpful tool. And where I envision this being particularly helpful with patients is, my patient who has adopted, serious lifestyle changes, they're exercising, they're lifting weights, and they're really not seeing a reduction in their weight on the scale. But if they can see how their body composition is changing with the exercise, that their lean mass is increasing, their fat mass is decreasing with the body composition scale, this can be very motivating for them to continue rather than seeing just this plateau on the scale. So I think we need better tools and that there are these inherent limitations in our BMI.
Thank you for sharing. That's all very interesting, considering that, BMI has been the standard for so long, and it's something that we are taught from the get-go. But there are so many other ways that body weight, obesity, and general health can be measured and should be measured, because it is more than just a number based on your height and your weight that depicts the health of the individual. And I wanted to go back and touch on a little bit of something that you talked about before. You mentioned carrying certain levels of adiposity on the body and how that can affect hormones and metabolism as well as body weight. And then you just touched on how that can be decreased a lot with exercise. But I wanted to ask if you have any specific tools that you've worked on nutritionally or with diet, or any other people that you've worked with in that scope, to try to address these things from a different angle than exercise and changes in lifestyle.
Yeah, absolutely. So I think the first step of this is understanding where your patient is at. So when I meet a patient, I take a detailed weight history, a detailed diet and exercise history, look at all of their medications, And then we see what we can change immediately to improve things. So, if the patient is consuming sugary drinks on a regular basis, this can be low-hanging fruit to target, right away. If they have diabetes and they're on a medication like a sulfonylurea that promotes weight gain, can I switch them to a medication like a GLP-1 receptor agonist that will promote weight loss? So there are often things we can do right away that'll make a big difference for their weight, their metabolism, the hormones that are contributing to their weight issue. And then, depending on the patient, they may have tried everything already. They may have, done every commercial diet program, worked closely with a registered dietitian, and they're really unable to lose weight. So I think at that point, we do consider anti-obesity medications, which can target appetite and other factors that may be contributing to their inability to lose or maintain weight loss. And then we consider bariatric surgery as a tool as well. So I think it's really understanding where the patient is at, and then lifestyle therapy with diet, with exercise is the cornerstone of any program, but we have tools beyond that to use if that isn't successful by itself.
Yeah, thank you for all that. Something I wanted to expand on that you talked about was how you take this detailed, patient history to start, and you really try to understand the patient. And something that within our student group and within our larger area of concentration that we try to talk a lot about in terms of nutrition and the intersection between nutrition and health and medicine is really learning about individualized care and, meeting a patient where they're at. And I think in medicine, a lot of times, a lot of physicians who may not have had access to a lot of nutrition education will give very generalized advice that doesn't always take into account things like, like you said, the patient's preferences, what they've tried and maybe have failed, and also other more specific stuff like their culture. If you try to get someone to eat something that isn't really part of their staple diet, it may not be a sustainable change. Which is something that I think we hear a lot about. And so I'd love to hear your thoughts into this, and what are some ways that you look at trying to really individualize your care for each patient.
Yeah, so I think all of these factors are so important. And I think if you have your one size fits all diet plan that you give all patients, they're not going to come back to see you because it's not helpful for them. And we know what's really most important for any diet plan is the ability to adhere to the diet plan long term. We've debated for decades the best macronutrient composition of the diet, and there's really no best diet. It's really the diet the patient can adhere to. So I can't underscore this enough, that we need to understand what the patient likes, what is sustainable for them. So we need to work with their cultural and individual preferences and not try to prescribe a one size fits all diet. So this is where, I ask them what they're eating now, what they like, what they dislike. Maybe they only like one vegetable, and if we can incorporate that, and maybe they like rice, but they're willing to try brown rice as a substitute, and then they find they don't like that. So then we're trying to find something else. So I think it's a process, and I think you need to see your patient frequently, know them well, and definitely, like you said, meet them where they're at, because the other approaches just won't be successful, and I think your patient will be discouraged and not want to continue.
Yeah, and I think that's a great point that kind of feeds into the overall theme that we've been discussing about, how obesity used to be looked at in the past versus the present. And, if we don't think of it as something like adherence and longevity and health longevity, and we're thinking of it as, a quick fix, try this diet, lose 20 pounds, but then what happens when they gain 40? And if we can start thinking of the ways that we can help patients, not just acutely, but also just in the long term, after we've helped them overcome whatever obstacle they've come, to see us with, and we've partnered with them, how can we partner with them, throughout life so that they're able then to take all the guidance that we've given them and be able to, live out in a healthy way. And I think there's such power in that and in what you've been discussing. And kind of we'd also love to touch upon, we've been talking about, all these different factors that have to do with obesity and this multifactorial aspect. And I think one of the big ones that we've seen being addressed a lot recently is just community factors. So, healthy food access, healthy food availability, a lot of different patient populations may be coming to us who are food insecure, who live in areas where, maybe the only produce they can get is frozen, is canned, maybe it's not even available. And so we'd love to hear more about your opinions on maybe how we as a medical community or just a larger community in general can help just to enable, healthy habit formation and be more aware of these when we deal with patients.
Yeah, so I think the environment plays a huge role, and it's hard to tell your patient to eat more fruits and vegetables when they're just not attainable. So I think, from a public health perspective, we do need initiatives. I was practicing in New York City where the green carts were established, and we're quite successful bringing fresh produce to, food swamp areas in New York City. And farmers markets, I worked in Washington Heights, which tends to be a lower socioeconomic neighborhood, but there was frequently a farmers market going on in the neighborhood and green carts available. So I think these were really helpful, and I think we need expansion of services like this in Westchester as well. And then, if patients rely on food pantries, I do encourage them to use what's available. So if it's canned fruits, canned vegetables, they can rinse off excess salt or syrups from the fruits. And there's a resource, there's a book called Eat Well on $4 a Day, Good and Cheap, which is by an author, Leanne Brown. And she actually designed a series of recipes based on the budget of somebody on food stamps or the SNAP program now. So I will refer patients to this, and it really takes advantage of in-season produce that may be more affordable, beans, high quality, nutritious foods that may be lower cost. So I do refer patients to that. And then in terms of exercise, it may not be safe to go outside in some neighborhoods. There are often, YMCA's, community programs, Silver Sneakers gyms that may be accessible for patients with Medicare, or even just free online exercise classes. So I think understanding what your patient, they may not have money for a gym membership and can't go outside. So really being creative and finding ways where they can add exercise to their day that's safe and accessible for them.
Thank you for sharing. I think that's a really interesting perspective, especially what you were mentioning about that book with different strategies to use when shopping at things like farmers markets and food pantries, and how you can turn that to your advantage when trying to adjust and eat healthily. And that leads into my next question that I wanted to ask, and I'm going to kind of tweak it a little bit. I wanted to ask, what are your thoughts on incorporating nutrition education into the medical school curriculum, and as well social education about these different programs and these different methods of meeting a patient where they're at into the medical school curriculum, and also how you think this is best accomplished?
Yeah, so I think patients look to their doctors for nutrition information. And unfortunately, most medical schools really don't prepare their students well to address this need by including nutrition and these resources as part of the curriculum. So I think what you and Jesse are doing with the culinary interest group is really incredible, and I feel that all medical schools should have something similar. And I think as you go through the curriculum and learn about hypertension, you should simultaneously learn the DASH diet and learn all of the nutrition approaches to treating hypertension. With diabetes, you could learn about the glycemic index and various, carbohydrates and which are high glycemic index and which are low glycemic index. So I think absolutely in the curriculum, we should be including nutrition as a treatment for disease. And there's really no side effects to using dietary changes to address disease, and it's vastly preferable to having to use medications with potential side effects. So I think it's overlooked. I think as a physician, you often don't have a lot of time with your patients or enough time, and it's easier for physicians just to prescribe a medicine than to do the work that's needed to understand where the patient's at and what you can do nutritionally. So I think there's a dire need, not only for the nutrition education you mentioned, but also preparing physicians to be able to connect their patients to community resources in order to have what they need from a nutrition perspective.
Yeah, and thank you so much for that. And I think you touched on it wonderfully, and just perpetuating the idea of physicians as patient guides and partners and in all aspects. And just because you're treating one thing in the patient's life doesn't mean you can't make an impact in multiple areas as well, which I think is so vital. So just to wrap it up, we always ask everyone this one question, which is, if you were going to present a dish on MasterChef, what would your signature dish be?
Yeah, so great question. Now that it's fall, one of my favorites is a sweet potato chickpea chili. I've made it for guests. My toddlers actually love it. So it's a sweet potato, chickpea, ground turkey chili. There's red pepper in it, a lot of vegetables, a lot of good lean protein in it. And to make it in the Instapot, it takes 7 minutes. So that's a favorite right now.
Thank you. That actually sounds really delicious, and I'm going to have to make an attempt to make that on my own at some point in the near future.
Yes, I'll send you the recipe for sure.
Thank you. We'll distribute it to our listeners as well. All right. Well, with that, thank you, Dr. Mullally. We really appreciate your time and this very interesting conversation. We touched on a lot of really good topics about how obesity is so much bigger of a problem in this country, especially, and how it can be addressed in so many different ways that don't necessarily have to be all that complicated. So we appreciate you taking the time to talk to us today.
Thanks so much, John and Jesse. It was really my pleasure.